ഒന്നോടെ ഫസ്റ്റ് സ്ലൈഡ് ഒന്ന് കാണിക്കാവോ? റെക്കോർഡിംഗ് തുടങ്ങുമ്പോൾ. യെസ്, സ്റ്റാർട്ട്.
Okay. So, very good evening to all of you. At the outset, let me thank KGMOA Kozhikode, especially Dr. Vipin Varki, the President, Secretary Dr. Salima, and the Academic Coordinator Dr. Dinesh for giving me this opportunity. So, in the next 30 minutes, I will be talking about the vaccines, some very important vaccines which are yet to be included in the National Immunization Schedule, but still in the IAP schedule and in the private schedule, we are still using it for the last so many years. So I will be discussing about these 5 vaccines: typhoid, hepatitis A vaccine, varicella vaccine, HPV vaccine, and influenza vaccine. And a minute. So I will be talking about the basic aspects of each vaccine and which are the available vaccines for each of these disease, what will be the schedule, what is the route of administration, etc. And finally, some frequently asked questions about all these vaccines. So coming to typhoid vaccine. So typhoid vaccine, as all of us know, we see a lot of cases of typhoid. And it is perhaps the 3rd most common cause of morbidity among the communicable diseases in India. And not only about the morbidity, it is responsible for 3% of mortality among deaths due to communicable diseases in India. So that is one important thing which makes a vaccine necessary for typhoid. So there has been a lot of different types of vaccines which were used in typhoid. The first generation of vaccines, it was a whole cell inactivated vaccine where either formalin, acetone, or heat or alcohol was used to inactivate the antigen. And those were the first generation of vaccines. They are no more used now. And the second generation of vaccine had 2 types of vaccine. One is the well-known, the live oral vaccine or the type oral vaccine. So this was the vaccine which was there when we were doing post-graduation lot. But now it is not available. It is a live vaccine. It is not available. And now we have 2 other important vaccines. Among the second generation of vaccine, we have the polysaccharide vaccine, the VI polysaccharide vaccine. And 3rd generation, we have a little more advanced, a conjugate vaccine, VI polysaccharide conjugate vaccine. So as far as typhoid is concerned, we have the polysaccharide vaccine, which is unconjugated, as well as the polysaccharide vaccine, which is conjugated. So these are the different unconjugated vaccines available. Like I'm not going into the trade names. And we have different unconjugated vaccines available. And these are the conjugated vaccines available. So the conjugated vaccines, we have the vaccines which are conjugated either to the tetanus toxoid or CRM 197, but both of them are equally effective. So to sum up, we have the unconjugated and conjugated vaccines, and these are some of the vaccines and conjugated vaccine. So basically, what is the difference between a conjugated vaccine and an unconjugated vaccine? Just like in the case of pneumococcal vaccine, we know conjugate vaccine is T-cell dependent. It is more immunogenic, and most important thing, a conjugate vaccine will be effective in less than 2 years, whereas a polysaccharide vaccine will be effective only after the age of 2 years. So in a younger age group, you have to use a conjugate vaccine. So what is done is that we are doing a conjugation of the VI polysaccharide with a protein carrier. It can either be a TT or some other carrier like CRM like that. So that is about conjugated vaccine. So coming to what is the recommended schedule of this typhoid vaccine? Nowadays, we are giving a lot of typhoid vaccine because for the food handlers, it has been made compulsory in the state of Kerala. So we are giving both conjugate vaccines as well as unconjugate vaccine. But comparatively, the conjugate vaccines are a little bit more costly. So the conjugate vaccine, what is recommended as per IAP guidelines is that the minimum age to start is 6 months, and up to 45 years, you can give the conjugate vaccine. And for a conjugate vaccine, it is given as a single dose. There is no need of any booster. IAP has categorically told that there is no need to give a booster for the conjugate vaccine of typhoid. And the dose is 0.5 ml, which is given IM. And it can be given at any age more than 6 months, and preferably it is given at the age 9 to 12 months. So it can be started along with the 9-month MR vaccine. Coming to the unconjugated vaccine, as I already told, it is can be started only after the age of 2 years. Dose is 0.5 ml IM. And one disadvantage of this unconjugated vaccine is that it needs to be repeated. Every 3 years, we have to give a fresh vaccine. So that is about unconjugated vaccine. So conjugate vaccine, at the 6 months, we can start. Unconjugated vaccine after the age of 2 years. So this is one point which I already discussed. Among the various conjugate vaccine, which is the best? And the answer is clinically, all are equally all are equally good, and anyone can be used. Conjugate. Some issue. Okay, so the next slide. For a child who has received only typhoid polysaccharide vaccine, you already gave typhoid polysaccharide vaccine to a child, and now you want to give a dose of conjugate vaccine. So what is the recommended time interval between these? So for a child who has received only the polysaccharide vaccine, we can give a single dose of conjugate vaccine after at least 4 weeks. So that is the recommendation. So this is a point which I already told. Can typhoid conjugate vaccine be administered simultaneously with measles containing vaccine? Previously, it was told that we cannot co-administer TCV and measles containing vaccine. But now it has been proved beyond doubt that the co-administration of TCV and MCV do neither result in any significant decrease in the antibodies of both the vaccines. So TCV and measles containing vaccine can be given on the same day. Now, a last question from typhoid vaccine. Does an unvaccinated child who has suffered from natural typhoid illness need a typhoid vaccine? So the answer is natural immunity after typhoid illness is suboptimal. So we can definitely give TCV anytime after successful completion of treatment. Another point which has to be added here is that after successful completion of all doses of vaccine, still the child can get typhoid? The answer is yes, because typhoid is a inoculum dependent disease. Depending upon the dose of the inoculum, or depending upon the dose of the antigen entering the body at any time, if it is a higher dose, the vaccine may not be able to protect the child. But still, if you have taken the vaccine, the course of illness may not be that severe compared with an unvaccinated child. Vipinji, can somebody admit the...
done.
Okay.
Already done.
Okay.
Going on.
Okay.
Oh, sorry.
Okay, fine. Now coming to hepatitis A vaccine. So hepatitis A disease, as all of you know, it is one of the most common cause of viral hepatitis in children, especially in developing countries like India. And the disease is food or waterborne. And recovery from a hepatitis A infection gives a lifelong immunity. But the tragic thing is that a very small proportion of people infected with hepatitis A can die due to fulminant hepatitis with a mortality of about 1%. That is a very, very important point. So that is the reason why you need a vaccine for hepatitis A. So we have inactivated vaccines available, which are more commonly used as of now. we have different inactivated vaccines from different companies like GSK, Sanofi, and majority of all the companies are producing inactivated vaccines of hepatitis A. And the schedule of the inactivated vaccine is like this. The minimum age of administration is 1 year. Starting from 1 year or 12 months, you can give the inactivated vaccine. And 2 doses should be given. It has to be given IM 6 months apart at a dose of 0.5 ml each. And there are adult formulations for 2 brands, for Avaxim and Havrix. There are adult formulation, but I think as of now, it is not freely available in our country, that adult formulation. And the cutoff age for this adult formulation is 15 years for Avaxim and 18 years for Havrix. And that is about the inactivated vaccine. We also have a live attenuated vaccine, which is called as BioVac, which is from the Vocard. So it is produced from the H2 attenuated strain of virus cultured in the human diploid cells. And the dose is 0.5 ml. And since it is a live vaccine, it mimics natural infection without much symptoms and all. And the schedule is single dose. So this is very important. The inactivated vaccine, we had to give 2 doses, but live vaccine, it is single dose, and the minimum age to start the vaccine is more than 1 year. So the point to note here is that for hepatitis A, the minimum age both for the live vaccine as well as the inactivated vaccine is more than 1 year of age. So which all groups should receive hepatitis A vaccine? So definitely patients with chronic liver disease, they should receive. Those who are carriers of hepatitis B and hepatitis C. Immunodeficiency disease patients, they can receive the inactivated vaccines. Transplant recipients, travelers to countries with high endemicity for hepatitis A, household contacts of patients with acute hepatitis A within 14 days of onset of illness. So this is a very important point. So when we are seeing cases of hepatitis A in a family, so if you can give the vaccine within 14 days of onset of illness, it may protect. So that is a post-exposure prophylaxis. Some FAQs on hepatitis A. If more than 18 months has elapsed after the first dose, then the course to be restarted or not? Definitely no. The second dose can be given. Only 2 doses are indicated, irrespective of the time gap. And the next point is a very important thing. For catch-up vaccination, do you require screening antibody titer? So as per IAP recommendation, pre-vaccination screening is recommended more than 10 years of age if the resources permit. And after this age, the estimated seropositivity rate exceeds 50%. So there is no recommendation to do a pre-vaccination screening. So, so in brackets, I have written if resources permit. It is not a must that you should do a pre-vaccination screening because giving the vaccine will be more economical than doing the pre-vaccination screening. So for your information, the antibody level of 20 international unit per ml is considered as protective for the pre-vaccination screening value. So this point I already mentioned. Post-exposure prophylaxis. So post-exposure prophylaxis, we can give from the age of 1 year to 40 years of age. We have to give the vaccine within 14 days after exposure. So up to 40 years, you can give vaccine. What about after 40 years? After 40 years, you can give the vaccine, but you may not be sure whether the vaccine will protect or not. So after 40 years of age, if you really want to protect, you have to give the immunoglobulin also. But unfortunately, it is not that freely available in our country. So after 40 years, if you want to protect, you have to give the immunoglobulin plus the vaccine. Less than 12 months, you cannot use the vaccine because the minimum age to start the vaccine is 1 year. So less than 1 year, the only option is to give immunoglobulin. If you cannot procure the immunoglobulin of hepatitis A, then you can give IVIG also. Both the killed as well as live vaccines can be used in post-exposure prophylaxis. Now coming to the third vaccine, chickenpox vaccine or varicella vaccine. So chickenpox, as all of you know, it is a highly communicable disease with a very high secondary attack rate of more than 90%. So, varicella zoster, as you know, it can cause primary infection, latent infection, and reactivation infection. So primary infection is the which manifests as chickenpox, and the latent infection remains in the sensory ganglion, and after years, it can reactivate and lead to herpes zoster or shingles. So this is the epidemiology of the chickenpox. It is very severe in adults, pregnant women, infants, and immunosuppressed individuals. And in tropical countries like India, older population is more commonly infected, and they are at risk of more severe infection also. So why is the vaccine needed? Even though chickenpox is a benign and self-limiting disease, it can sometimes be associated with complications like pneumonia, secondary bacterial infection, cerebral ataxia, encephalitis, and rarely death. So, and the complications are more common in the immunosuppressed individuals. So that is the reason why you need a vaccine. So which is the vaccine available? We have a live attenuated vaccine. Hope all of you remember this, this strain, V-Oca strain. So all our current vaccines available for against chickenpox are derived from the V-Oca strain. And this Oca strain undergoes different passages, several number of passages through different cell lines, 11 passages through the human embryonic lung cells, 12 passages in the guinea pig embryo cells, and 1 passage in the human diploid cell, WI138 cells. So this is the composition of the varicella vaccine. So these are the different varicella vaccines available. We have the different companies which produce the varicella vaccine. So this is the schedule and the dose of vaccine. So here also, the vaccine is licensed only above the age of 1 year. So the minimum age where you can give the vaccine is 12 months. And the risk of breakthrough varicella is lower if given 15 months and above. I will come to what is breakthrough varicella in the next few slides. So the dose is 0.5 ml. Being a live vaccine, it is given subcutaneously. What is the IAP recommendation? IAP recommends to give the first dose at 15 months. So even though it can be, it is licensed beyond the age of 12 months, the first dose as per IAP is to be given at the 15 months. And second dose, we have to give at 3 to 6 months after the first dose. So if you are giving at 15 months the first dose, second dose will be either at 18 months or between 18 to 24 months. There is a difference between ACVIP recommendation and CDC recommendation. Even ACVIP around 3 or 4 years back was recommending the second dose to be given after a few years. That is, first dose at 15 months and second dose between 4 to 6 years was the previous recommendation. CDC is still following that, but as per the latest ACVIP, the recommendation is first dose is 15 months and second dose 3 to 6 months after first dose. What about the catch-up immunization? So this is very important. So for children who are below 13 years of age, you can give 2 doses 3 months apart. And children above 13 years of age, you can give 2 doses at an interval of 1 month to 2 months. So less than 13 years, 2 doses 3 months apart. More than 13 years, 2 doses 1 to 2 months apart. So what is breakthrough varicella? So breakthrough varicella is the varicella which occurs in children who have been vaccinated more than 6 weeks after vaccination. So after 6 weeks of the vaccination, the child is getting varicella. The breakthrough varicella is found usually to be generally milder and may present with just short-lasting maculopapular rashes and may not progress to the vesicular stage. So it may not present with the typical vesicular lesions of chickenpox. The child may not be having fever, but it will be a milder version of varicella. But the important thing is that breakthrough varicella, even though mild, it is infective. And if you get an infection of varicella through a breakthrough varicella, it can present just like any other case of varicella. So it is infective. So what are the risk factors for breakthrough varicella? The first point I already told. vaccination below 12 months of age. That is the reason why IAP is recommending the first dose at 15 months of age. Not observing 28 days interval with MMR vaccine. That is another important thing. MMR or MR vaccine, both are live vaccines. So you have to give at least 1 month or 28 days gap between both these vaccines and immunocompromised children. So these are the risk factors for breakthrough varicella. Now coming to post-exposure prophylaxis. This is a controversial thing. Many times, our patients will be coming to us and asking, in our family, we are having one case of chickenpox. There are 2 other kids in my family. Can vaccine be given? Theoretically, we can say that if you give the vaccine within 72 hours or within 3 days of exposure, there is a protective efficacy of more than 90%. So you can protect them theoretically, but it depends upon how close the child was during these 3 days or before, even before the it was clinically manifesting, the child was in contact. It depends on a lot of factors. But theoretically, if you give within 3 days, you can protect 90%. And even if you are giving the vaccine within 5 days, the protective efficacy for preventing any type of chickenpox is 62.3%, and the protective efficacy for preventing the severe manifestations is around 80%. So that is about the post-exposure prophylaxis. So what is the take-home message from this slide? So whenever the child is coming to you and the parent is asking whether I can take post-exposure prophylaxis, you can advise post-exposure prophylaxis, even if the child, the number of days of exposure is more than 3 days or more than 5 days, because if the child is not getting varicella at that moment, in that episode, it will further protect him. So you can definitely advise the vaccination. Now coming to the next vaccine, human papilloma virus vaccine or the HPV vaccine. So human papilloma virus, it is a virus which is responsible for the cervical cancer. So there are different strains of HPV virus, and in the Indian scenario, 2 strains, that is the HPV 16 and 18, they contribute to around 80% of all invasive cervical cancers. And a further 16.7% is contributed by another 3 strains, 33, 35, and 45. So this is a very important picture. HPV causes more than cervical cancer. It is not only cervical cancer that HPV is causing. It can produce penile cancer in males. It can lead to vulvar cancer, vaginal cancer, anal cancer, head and neck cancer, and a lot of other diseases like genital warts also. So that is a very, very important disease. So what is the need of vaccination rather than waiting for the natural infection? So the important point is that in HPV, the natural infection induces a weak immune response. So it is a locally affecting disease. There won't be much inflammation. There will be local immunosuppression only. There won't be much viremia also. On the other hand, if you are taking a vaccine, it induces higher antibody levels in the blood, which means higher antibody levels at the site of infection. So ultimately, the antibodies neutralize the virus and prevent their entry into the cells. So what are the contents of the present generation HPV vaccine? The current HPV vaccines are based on VLPs, or the virus-like particles that are formed by HPV surface components and resemble the viral surface. They lack the viral DNA. These virus-like particles, they are not like a live virus. They are non-infectious, but at the same time, they are highly immunogenic. And addition of adjuvants make them more immunogenic. So these are the 3 HPV vaccines which are currently available. At this moment, I take this opportunity to congratulate KGMOA Code, especially the women's wing of KGMOA Code, who took an initiative to vaccinate all their members and their family members against HPV vaccines at a subsidized rate. So congratulations for arranging that rate. So these are the presently available vaccines. We have two 4-valent vaccines, which contains 4 strains, that is 6, 11, 16, and 18. We have Gardasil 4 and Servavac. Servavac is a Indian variant from an Indian company like the Serum Institute. We also have the nonavalent or the 9-valent vaccine. 9-valent vaccine is the same name, but it is Gardasil 9. It contains 31, 33, 45, 52, and 58 other than the 4 strains. So these are the available HPV vaccine: Gardasil 4, Gardasil 9, and the recent introduction Servavac. Gardasil 4 is recommended only for girls, but Gardasil 9 as well as the 4-valent Servavac, they are recommended for both sexes. Now coming to what is the schedule which is recommended. So for the 9 to 14 years girls, so the 9 year is the minimum recommended age for the vaccine. For the 9 to 14-year girls, you can use both the nonavalent as well as the quadrivalent vaccines. In this age group, they are recommended in a 2-dose series with a minimum gap of 6 months between the doses. So the gap between these 2 doses is extremely important. I will come to the details later. So in this age group, in girls, we have to give 2-dose series with a minimum gap of 6 months. What about boys? In this same age group, in 9 to 14-year boys, we can give only the 9-valent vaccine, which is recommended in a 2-dose series with a minimum interval of 6 months. As age advances, in the age group 15 to 45 years, we have to use a 3-dose schedule. If it is for HPV, we have to give 3 doses of the quadrivalent vaccine at 0, 2, and 6 months. And if it is Gardasil 9, we have to give 3 doses at 0, 2, and 6 months till 26 years of age. We can give only till 26 years of age. The recommendation is based upon the available studies, because the available studies in India for this peculiar vaccine is only till 26 years. That is the reason why it is recommended only till 26 years. So another important thing that we have to remember is, irrespective of the age, if the patient is immunocompromised, we have to give 3 doses. So that is very important. For immunocompromised individuals, 3-dose series is there. Now coming to 2 important points. In a 2-dose schedule, I already told 2-dose schedule, the recommended interval between the doses is 6 months. So the minimum interval should not be less than 5 months. If the second dose is administered after a shorter interval, we have to consider as an invalid dose, and we have to give a 3rd dose. So if the second dose is administered after a shorter interval, a 3rd dose should be administered at a minimum of 5 months after the first dose and at a minimum of 3 months after the second dose. So that is one important recommendation. This is for the 2-dose schedule. In a 3-dose schedule, you are giving 3 doses. The minimum interval between dose 1 and 2 should not be less than 4 weeks. You should not give the first and second dose should be separated by more than 4 weeks. And the minimum interval between dose 2 and 3 should not be less than 12 weeks. And the minimum interval between dose 1 and 3, the first and third dose, there should be a minimum interval of 5 months. So if it is less than 5 months, it should be considered as an invalid dose and you may have to repeat the dose. So I think you understood that point. So just to keep in mind, the minimum interval between the first and second dose in a 2-dose schedule is, it should not be less than 5 months. And in a 3-dose schedule, the minimum interval between the first dose and third dose should not be less than 5 months. This is Servavac. This is a recently introduced product from the Serum Institute of India. Now coming to influenza vaccine. Influenza vaccine is a influenza as such is a often misunderstood disease. We should always remember influenza is not just a bad cold. It is a serious, just like COVID and all, serious. So we have the annual influenza epidemic, and sometimes in some places we get the pandemics also. I hope you remember this picture. This was taken from our microbiology textbook. The antigenic drift and shift. So antigenic drift is due to minor changes in the viral genome. It occurs both in the A and B strains. It is basically due to point mutation and results in a newer strain. And it keeps on occurring. Every year, the antigenic drift occurs. On the other hand, antigenic shift is due to a major shift in the genome. It is usually seen and only seen in the A strain of influenza virus. It is due to gene reassortment, and it results in a new subtype. So we have to keep in mind an antigenic shift can lead to pandemics of influenza, whereas the drift of antigenic of the virus will produce the epidemics of the seasonal influenza. Influenza vaccine is unique. Compared with other vaccines, it has got many unique features. So I already told it has got the shift and drift phenomena. And every year, the strains, the characteristics of the strains keep on changing. So there is an entity which is called as the GISRS, or the Global Influenza Surveillance and Response System, which regularly updates the guidelines to the manufacturers regarding the southern and northern region circulating strains. That means, based upon the circulating strains every year, the manufacturers have to make some subtle changes in their strains. So we have the southern hemisphere vaccines, which are available by March and April month, and the northern hemisphere vaccine, which are available by September, October month. So we have different strains of vaccine. Now coming to the recommendations by different national and international bodies. So World Health Organization and CDC recommends routine influenza vaccination to all persons more than 6 months of age. But IAP is not routinely recommending for all age group. As per IAP recommendation, it is recommended from 6 months to 5 years, but still it is telling based upon the prioritization, you can give to all age groups, and it is definitely protective to influenza virus. And so even though the routinely IAP is not recommending to all age groups, we are, in all practical purposes, we can prescribe influenza vaccine for any child who is more than 6 months age. So this is the dose, 0.5 ml of the inactivated vaccine, starting from 6 months. And the second dose is given after 1 month. Same dose, 0.5 ml is given. And it is usually given in the pre-monsoon period. So as far as Kerala is concerned, we can give it in April, May, because monsoon start in Kerala from around June middle. So we can give in April or May. We have the quadrivalent and trivalent vaccines available, but what is recommended as per the ACVAP guidelines is to give the 4-valent vaccine or the quadrivalent vaccine. So these are the different quadrivalent vaccines which are available in our country, Q-Quadri, Influvac, Tetra, and Vaxipro and all. So Among these, the type of vaccine may vary. Some will be a subunit vaccine, and some others may be split virion vaccine. So this is the basic difference between the split virion vaccine and the subunit vaccine. So the viral components in the vaccine, in a split virion vaccine, only the outer and inner viral antigens will be present. But in a subunit vaccine, it is subunit, it has the only purified external antigens only. When you consider the immunogenicity, seroprotection, T-cell immune response, everything is comparatively higher for the split virion. But still, SCVAP is recommending you can give either of split virion or subunit. There is not much difference in our practical purposes. So what is the SCVAP recommendation regarding dose of vaccine? So I already told 0.5 ml is recommended to all above 6 months of age. From 6 months to 9 years of age, we have to give 2 doses when given for the first time and followed by single dose yearly thereafter. After the age of 9 years, we need to give only single dose even if you are taking it for the first time. So what is the dose? Previously, we used to say in younger age groups, we had to use a reduced dose of 0.25 ml. But now, because we are not using the whole cell vaccines now, so we can use the full dose of 0.5 ml. So moreover, 0.5 ml is immunologically superior in the younger age group. So IAP is uniformly recommending a standard dose of 0.5 ml for all age groups. Now, some frequently asked doubts about influenza vaccine. A 3-year-old child comes for flu vaccine. He had taken only 1 dose last year. How many doses should this child receive this year? So here you have a child who has come for the flu vaccine. He has taken 1 dose at the age of 2 years. So ideally, any child who is less than 9 years, you are supposed to start the vaccination with 2 doses, 1 month apart. But this child has taken only 1 dose initially. So in such a child, any child who has received less than 2 doses in the past, he should receive 2 doses again in this season. So this child, if is coming to you this time, then you give 1 vaccine this month, and the next month you give the second dose. So any child who has received less than 2 doses in the past should receive 2 doses again in this season. Another frequently asked question, a 4-year-old child has received 2 doses in his first year of life and none after that. He come now for his influenza vaccine. How many doses should the child receive? So he has missed his yearly doses, but initially when he took, he has taken 2 doses. So any child who has received 2 or more doses in the past, these doses need not be in the same season. Then he should receive only 1 dose again. I hope this is clear for you. So at the first visit or the subsequent visit, totally if the child has taken 2 doses at any time, then only yearly single dose will be required. So this is the last slide. After recovering from flu, does a child need a flu shot and when? Because as I already told, there are different strains of influenza viruses. The vaccines contains 4 strains, and we don't know whether the child was infected with which strain. So if the child was infected with another strain, which is included in the vaccine, will definitely protect against that strain. So to protect against other strains, he can definitely take the vaccine after clinical recovery. So that is about this presentation. Thank you so much for your patient listening. Dr. Vipin?
Dr. Krishnamohan.
Salima ji, hi.
Hi. കുറച്ച് ലേറ്റ് ആയി കയറാൻ. ഡൗട്ട്സ് എന്തെങ്കിലും ഉണ്ടെങ്കിൽ ക്ലിയർ ചെയ്യാൻ തോന്നുന്നു. ഡൗട്ട്സ് എന്തെങ്കിലും ഉണ്ടെങ്കിൽ ചോദിക്കാൻ തോന്നുന്നു അല്ലേ? എത്ര സമയം കിട്ടും?
എനിക്ക് 8:45 വരെ കുഴപ്പമില്ല, സമയമുണ്ട്.
Okay.
There is one question in the chat box. If chickenpox vaccine 2 doses given, will it give lifelong immunity or booster needed? So chickenpox vaccine, the inactivated vaccine, if given 2 doses, complete 2 doses is given, theoretically it gives lifelong immunity. Studies have proven that it will protect up to 17 to 20 years. And the live vaccine also, after a single dose, it will give equal protection.
ഒരു ഡൗട്ട് ഉണ്ടേ.
ആരെയായിരുന്നു കാണുന്നില്ല.
ഞാൻ ഡോക്ടർ ധന്യ കൃഷ്ണമോഹൻ.
ഓക്കെ.
അത് നമ്മളിപ്പോ പ്രൊഫഷണൽ കോളേജിലത്തെ കുട്ടികളൊക്കെ ചിക്കൻ പോക്സ് അതുപോലെ ഹെപ്പറ്റൈറ്റിസ് ബി ആൻഡ് MMR വേണ്ടി വരുന്നുണ്ടല്ലോ. അപ്പൊ അവരെല്ലാം ഓൾറെഡി ഇമ്മ്യൂണൈസ്ഡ് അപ് ടു ഏജ് ആണ്. അപ്പോഴും ഈ ഹെപ്പറ്റൈറ്റിസ് ബി ഒക്കെ 3 ഡോസ് ഷെഡ്യൂൾ തന്നെ റിപ്പീറ്റ് ചെയ്യണോ?
ഇല്ല, അവർ ഓൾറെഡി ഇമ്മ്യൂണൈസ്ഡ് ആണെങ്കിൽ അവരുടെ ഇമ്മ്യൂണൈസേഷൻ കാർഡ് ഉണ്ടാവില്ലേ?
ഇല്ല, ഇമ്മ്യൂണൈസേഷൻ കാർഡ് പലരുടെ കയ്യിലും ഇല്ല. കാരണം ഓൾമോസ്റ്റ് ആ ഏജ് ആയില്ല, അവരുടെ കാർഡില്ല. പക്ഷെ അവര് അമ്മയൊക്കെ പറയുന്നത് എല്ലാം കൊടുത്തിട്ടുണ്ടെന്നല്ലേ ആണ്. പക്ഷെ ഈ 016 പിന്നെ റിപ്പീറ്റ് ചെയ്യണോ ഈ പ്രൊഫഷണൽ കോളേജ് ചേർന്നവർക്ക്?
We cannot believe them what they are telling. And if you want to give the certificate, we definitely have to give the vaccine.
അപ്പൊ 3 ഡോസസും കൊടുക്കുക അല്ലെ?
Yes.
അപ്പൊ പിന്നെ ഒരു കുട്ടിക്ക് ചിക്കൻ ബോക്സ് ഹിസ്റ്ററി ഓഫ് ഡിസീസ് ഉണ്ടെങ്കിൽ കൊടുക്കണോ ചിക്കൻ ബോക്സ് വാക്സിന്? വേണ്ടല്ലോ.
ചിക്കൻ ബോക്സ് ടിപ്പിക്കൽ വെസിക്കുലർ ലീഷൻസ് ഒക്കെ വന്നിട്ടുണ്ടെങ്കിൽ you need not give. You're definite with that.
Okay, thank you.
Because natural infection gives lifelong immunity in chicken pox.
ഒരു ഷുവർ ആണെങ്കിൽ പിന്നെ കൊടുക്കണമെന്നില്ല അല്ലെ?
But for typhoid and all, even if the patient had typhoid, culture proven typhoid, even after that you have to give typhoid vaccine.
അത് ടൈഫോയിഡ് അതേപോലെ ഡൗട്ട് ഈ നമ്മൾക്ക് ഫുഡ് ഹാൻഡ്ലർ സർട്ടിഫിക്കറ്റ് അവർ എവറി 6 months വരുന്നില്ലേ? അപ്പൊ ഓരോ തവണയും ടൈഫോയിഡ് വാക്സിൻ എടുക്കണോ?
No. Typhoid vaccine, if you are giving the conjugate vaccine, it is only 1 dose is required. If you are giving the polysaccharide vaccine, it has to be repeated. It is not a booster. It has to be repeated after every 3 years. So if a patient has taken a vaccine in 2023, he will be protected till 2026. And till that date, you need not make the patient take an extra vaccine. You can give the certificate with that.
Okay. Thank you.
Another doubt in the chat box. A child 2 years had only 1 dose varicella vaccine. Should he receive 2 doses again if he missed a second dose? Yes, if it is a inactivated vaccine, he definitely needs a second dose. So it can be given irrespective of the gap between the first and second dose. He can receive the second dose then. Somebody has asked the MMR vaccine is available or not. MMR vaccine is available, not in our government schedule. I think it is still available in the private sector.
Sir, MMRV
MMRV or the this thing multiple varicella with the MMR. It is not available in India. It is not available.
Okay, sir.
In the northern hemisphere, influenza vaccine yearly will be updated by September-October month. Shall we wait for the new strain this year? So there was a confusion regarding this, regarding the southern hemisphere, northern hemisphere, and not. Even though position-wise India lies in the northern hemisphere, but the disease pattern and all, it behaves more of a southern hemisphere region. So previously it was told we have to give the southern hemisphere vaccine. But the latest IAP recommendation is telling, irrespective of all these things, you go for the vaccine which is the most recent. You need not have to think about whether it is northern hemisphere vaccine or southern hemisphere. Whichever vaccine is available, which is the most recent one, you go for that. That makes the thing very simple. Somebody has asked, sir, influenza vaccine taken in September or October this year, next year should they wait till September? No, next year they need not wait till September. Ideally, what you are supposed to do is that you have to take it in the pre-monsoon season. So as far as Kerala is concerned, monsoon will be beginning from June and July. So we have to give at least 1 or 2 months before. So April, May will be ideal. We need not have to wait till September because it won't protect them.
If second dose is missed, should take both first and second, or only
No,
second
no,
dose?
only second dose. It is not only for varicella vaccine. For any vaccine, if you are missing a vaccine dose, you start from the point where it was stopped. There is no need to restart it.
Which type of varicella vaccine is better in India? Already explained, alle.
Yeah, we have inactivated as well as live vaccine, but more in use is the inactivated vaccine. Both can be used. Which company is better, I don't know.
Any more doubts?